For he who has health has hope, and he who has hope has everything. Owen Arthur.
Hey, what's up, guys? Welcome back to another episode of Mentality. It's your boy Gambo, and today I have a special guest with me. Today we're talking to Nadeem Fazal. We're going to be discussing some of the racism and lack of access within the healthcare system in the United States. Stay tuned as we chop it up in another interesting episode. All right, welcome back to the show, guys. Nadeem, how you doing today, brother?
Doing well, man. How are you doing?
Hey, man, I can't complain. It's Friday and feeling really good. So, we have you on the show today, and it's a pleasure to have you on the show. I want to be able to give you a chance to introduce yourself, but from knowing you've been a huge advocate for those seeking healthcare access, and you've studied a great deal in the healthcare industry, and so I wanted to kind of get your thoughts on a couple questions today. So please introduce yourself if you will.
Definitely. And thanks for having me on the show, Isaac. Really excited to talk about the topic. In terms of my background, um, we went to University of Delaware, and it was kind of there where I really found my interest in public health, specifically within healthcare. So trying to understand how we can for the health of countries and regions more broadly. So less so focusing on the individual at the medicine level, but looking at a population level. And from there is kind of where I got interested in the business aspect of it. So from there, I had went to Columbia to study my master's in public health, specifically health policy, and now I am a business consultant. So I work in healthcare strategy and try to basically find the intersection between public health and corporate strategy.
Nice. Now there's a lot of big mumbo jumbo right there, but all I heard was I'm a big healthcare guy. No, I'm joking. But so that's awesome, man. So today's topic we pretty much wanted to kind of cover, healthcare and the lack thereof within certain communities, especially the black and brown communities. But I
Right.
think before we had that kind of conversation, I wanted to touch based on like, what healthcare looks like within the United States and the current status of it. I mean, I feel like whenever you hear healthcare, especially in the United States, you hear that it's not that good, and so I
Hmm.
kind of want to be able to uncover that a little bit and kind of dissect that, and then
Right.
further move towards why there is a lack thereof of healthcare within certain communities. Um, so I guess like whenever you think of healthcare in the United States, like why is it considered to be bad when compared to other countries?
You know, it's an interesting question because there's so much to say about the topic, but I think the biggest thing that stands out when you think about US healthcare is that the US health system, whether it be Medicare, Medicaid, private insurers like Aetna and Cigna, and physicians, there's a lot of money that goes into making healthcare better,
Mm,
either in terms of the services that they provide in hospitals or the technology that's available or the pharmaceutical drugs that are coming to market. There's a lot of money and a lot of investment,
mm,
but the health outcomes don't necessarily prove that ROI, if you will, or they don't
mm.
necessarily prove the outcomes that you would think if you're spending this much amount of money. So we're spending three times the amount that any healthcare country or any country is investing and
Wow.
spending. However, they're having better outcomes than we are. So everybody is always perplexed as to, why is that the case?
Yeah, that's actually really weird. I didn't know that was the case. And
Spend a
so
lot of money on healthcare.
yeah, like I know it's in the trillions. I heard it was like 17% of GDP or some shit like that. So I know the number is very high, and I'm really, it's interesting that you say that. So is it more so like the fact that our strategy is not, the best strategy in terms of like implementing healthcare, or is it a population density kind of thing?
So I think, in in my opinion, I think it stems back to social justice and equality and social equality from years and years ago. But from at least from a healthcare perspective, I kind of think there's like three barriers. So, the first is kind of how we consume care and what that means from an access perspective, from an affordability perspective, and then like from an availability perspective. But then there's like other things as well, such as the levers of life, if you will, for that are kind of the ways and the means and the ability for you and I to consume the care. But then underneath all of that are, the social equality underpinnings that govern those means and abilities to consume that care. So I think those social justice underpinnings are super prevalent within the United States specifically, given our history, given the divide, not just racially, but in other social groups and other social circles that aren't necessarily as prevalent in other countries.
All right, can you touch more on the underpinnings? Like, what do you exactly mean by that?
Sure. So I think the best example to explain that is the Tuskegee study that was conducted by
Yeah,
the United States Public Health Service.
yeah,
It was done about a century ago. Um, but I guess to just kind of give a little bit of a description as to what it is, because maybe not everybody knows what it is.
yeah.
It was a study that was conducted by the U.S. Public Health Service, and it was conducted over a span of 40 years. So it's a super long study. And what it was supposed to do was study the disease progression of syphilis. However, when the US PHS was recruiting patients and recruiting participants, they specifically tried to recruit African American males. However, they lied about the purpose of the study and mentioned that the participants would be getting free treatment
Mm,
when both of those things were not true. And I think that just perpetuated the fact that there was racial inequality in terms of how we view African Americans at the time. And I think that exacerbated a sense of distrust in the healthcare system.
yeah, yeah, not for sure. And I think even when you look at modern days, right? I think a lot of the distrust that you see within certain communities, especially the black and brown communities, and when it comes to healthcare, I think is still very, very prevalent. You see a lot of people, not trusting doctors. They're not trusting the healthcare system.
Hmm.
And a lot of times when you're from the outside looking in, it could seem like almost irrational. But these historical things that have happened
Right.
have laid down a roadmap for it to get to where it is right now. So it is
100%.
unfortunate. And so like I guess we could touch more into that, like more on that a little bit later in our talk. And I'm
Sure.
glad you brought up the Tuskegee study because I actually want to learn more about it.
Sure.
But as of right now, like pretty much when looking at the United States healthcare state,
Mm,
you mentioned like a lot of these underpinnings and a lot of like things that have been done that kind of like make it not so great. And I'm still like trying to wrap my mind around the monetary aspect of it, of like how we're spending so much more money than people, but
hmm
the care is still considered not good. So in my to my understanding, when care is not considered to be good, it's usually
hmm
because maybe in the country the care is not affordable, or maybe
Right.
the quality of care is just not that good, or the ease of
Right.
access is just not there, or maybe
Right.
even the overall health of the populace is not to standard, right?
Right.
So I guess like when we look at countries who are considered to have good health care, like what Canada,
Right.
Germany, these
Sure.
countries,
Yeah.
like is that the four things that I mentioned, is that kind of what drifts us apart, like in terms of affordability, like upfront costs, ease of access, like the overall like health of the people within the countries. Is that like kind of what is that kind of why people look at us and say, well, the United States does not have good healthcare, obviously in conjunction with the fact that we're spending so much money and it's just not showing.
Right. It's a fair question because if you spend all that money, you would think that we would have really good outcomes or really like high quality care or high quality care and good outcomes,
Right.
but that's not the case. Um, I guess a good example or a good way of describing that is using the words by the wonderful Bernie Sanders.
Oh
And
God.
yeah, he said something along the lines of in one of his speeches saying, I have access to buying a $10 million house, but I don't have $10 million. I don't have the money and I can't afford a $10 million house.
Okay.
So we're developing ways to get insurance. We're developing ways to ensure that people are not uninsured. And we're developing new treatments, new services. We're doing all of these things, developing new drugs, new technology, so that way we can better identify cancer earlier. So that way we can treat and prevent diseases earlier. But that doesn't necessarily mean that you and I are going to have those outcomes.
Mm.
And I think for me, the reason for that is more so around like the social determinants of health, like different socioeconomic factors. And these are things that I think go beyond healthcare, but it's, you know, the right to and access to education, quality education, the right and access to affordable housing, the social justice policy in place to mitigate implicit bias, whether it be in healthcare or outside of healthcare. And that's something that we've seen today, you know, given recent events as it relates to discrimination and racism. And
Right.
I think those events have a downstream effect on people's health and their livelihood, and they also impact the structural quality of our healthcare system as a whole.
Yeah, man. Okay, so that actually makes a lot of sense. I mean, because like we mentioned earlier, obviously we still see some of those downstream effects in
Hmm.
certain communities, and obviously there are historical implications that have led to this. Um,
Right.
so, what are we doing to better the overall system of healthcare in the United States as a whole? And do those plans involve Black and Brown communities to obviously get better, to be able to
Hmm.
help them build more trust with the healthcare system, and to
Hmm.
also help them be able to gain more easier access to quality and affordable healthcare?
It's a good question. And I wish I had all the answers to solve something like that, because
Right.
the people that have the least amount of access and have the hardest time receiving access due to things that are out of their control are where the healthcare system struggles the most. So, to answer that question in terms of what we're doing, there's lots of policies being developed to address better access, race agnostic, such
Mm.
as the Affordable Care Act.
I did
The,
want to talk on that, but I'll let you get to it.
so, the Affordable Care Act is there to provide insurance that for people that otherwise would have a hard time receiving insurance. And, it's basic coverage, that allows for, very basic preventative services that would otherwise be very difficult to attain because insurance is expensive. You and I both know that, and that now that we're working
Yeah,
and we pay
yeah,
for insurance, it costs a good chunk of change, I would say.
yeah.
So imagine having to pay for that for yourself and for two kids if you're a single mother. So there's policies like that, but in terms of specifically for Black and Brown families and communities, there's no policy specifically oriented towards that. But I think what is happening in the healthcare system and by specific entities like large academic medical centers, they're they're building these things called social determinants of health centers where they're actually studying the holistic experience and the holistic life that
Mm.
any one patient would have outside of the office visit. So that way they can kind of learn more about, okay, what are the driving factors that are still preventing people from having good health? But beyond that, it it's still a work in progress, as you would say.
Okay, so this is looking at what is preventing people from having good health, but not
Hmm.
looking at what's preventing people from having good access to healthcare. Right? Am I getting that correct?
Hmm. Hmm.
Okay, so I would say those are two very different things, right? I guess in terms of like health, I mean those could be like genetic, underpinnings, or
Sure.
like also environmental things, like such as like having being around food deserts, or just not having access to like good food or anything like that,
Sure.
right? So, or even lack of education, that could be a part of that. But as opposed to like as on the contrary, when you look at healthcare, like I know when growing up in New York, like in the Bronx, right? Like, or even other
Hmm.
other places that I've lived in my life. Typically, we don't have like hospitals. Like we would have like clinics, or
Right.
like these little like rinky dink type places where if you needed anything, that's where you would go to.
Okay.
So that's kind of what I'm alluding to is like, are we doing anything to kind of to obviously, like laws and legislature like such as the Affordable Care Act, or one thing which I will certainly touch on more, but like in terms of like infrastructure, or in terms of like, getting the healthcare professionals to be able to cater to certain environments or certain
Right.
neighborhoods,
Right.
are we actually actively doing something about that?
So that's an interesting point, because I think that alludes to a specific aspect of healthcare that I study. So, when I was talking about like kind of the tip of the iceberg, like there's access, affordability, and availability.
Yeah.
Availability is kind of like what you're getting at, which is,
Yeah, yeah.
the amount of or the level of healthcare personnel or the right technology that can serve the care and the treatment that you need. And in certain areas, that level is very low. Um, and I think some of the policies that have been instituted in the past have been to increase the number of physicians available in certain areas, and as well as the number of physicians that are black versus white, because there is not only a shortage of physicians,
Okay.
primary care physicians specifically, that would otherwise deal with preventative care, but there's a significant shortage in the number of African American physicians. I think it's around 3% of all medical school graduates are black.
So are you saying that if we have more physicians of color, we would subsequently like improve the availability of care?
So I think, and that's like a half finished point. So
Okay.
thank thank you for reminding me. So the this the outcome that having a more diversified pipeline in workforce and healthcare, I think would address the distrust that happens
Mm,
in healthcare today. And the reason why I say that is because research from what I found recently says that I think 34% or a third of like study participants receive better care
mm.
if they're seen by same race, specifically African
Interesting.
American patients. So the conclusion of that study was that, you know, they're receiving better care because they trust the provider more. And having the lack of those types of physicians, having the lack of African American physicians, I think limits the ability to deliver the care that we should be able to.
That's honestly 1,000% accurate. I can attest to that because I feel like even for someone like me, I feel like whenever I have someone who I feel like has my vested interest or my best interest
Right,
at heart, like I'll feel more comfortable and I'll be more
right,
likely to go back to that person. You know,
right.
regardless of like I wouldn't wait to have an issue first. If I had the means to, I would go back to that
Hmm.
person. So I actually
Right.
wanted to share like a story. Like I don't like so you know this, but I mean I don't know if I think I've actually talked about this on here before.
Okay.
I no not too long ago I actually injured myself, my leg.
Hmm.
So I had an ACL injury where I tore my ACL,
Hmm.
LCL, or my MCL or something like that. I tore
Right,
like three
right,
ligaments, so like my knee was pretty blown out.
right.
But upon that happening, also like when that happened, I wasn't even thinking about going to the hospital. Like my friends who I was playing ball with, like was like nah, like it's down the street. You should go. But this is the mentality for me. It's like
Hmm.
my mindset was like, nah, like whenever we get hurt, like you take Robitussin or you put some Vicks on it, you'll be alright. Like you know what I mean? Like
Right.
seriously. So I'm thinking, nah, I'm gonna just take some painkillers and I'll be alright. But my
Hmm.
leg was seriously in pain, and so when I went to the hospital, I went to the emergency room actually.
Hmm.
Um, what do you call it? They looked at me and I felt like the care was haphazard because when they looked at me, yeah, they did an X-ray. There were no
Hmm.
broken bones. I told them my physical state,
Right.
but they didn't even like consider my pain. They just kind of said, "Oh, it looks like you're fine." They honestly made me feel like a bitch a little bit. I ain't gonna lie to you.
Right.
Like,
Yeah. No.
nah, they were just like like oh, like you might here's a brace if you need it. Maybe here's some crutches if you need it. But you shouldn't need it. If your leg still hurts in 2 weeks, go see an orthopedic. So I was
Hmm.
like, okay, like obviously maybe I'm just like bitching right now, but
Yeah.
after 2 weeks, I went to go see an
Hmm.
orthopedic doctor, and he was like, I don't know why they didn't even do an MRI, but your
Hmm.
ligaments are like severely like they're torn. I mean, like
Right.
completely torn. Like you need surgery. Like it's not even a question of should you or not. You kind of
Hmm.
need that. It's kind of crazy that like if you're playing soccer, like you would think that's probably something that
Hmm.
you should think about as an
Right.
ACL injury, but that was not the case. And so I think that proved to me two things. One was like the lack of, I don't want to say empathy, but I want to say like
Hmm.
it was like that trust right there. I could have easily like been distrustful like in the future, right?
Right. Right.
And also on top of that, it's like not only is there the distrust factor, it's almost like they don't consider your pain. It's almost like
Hmm.
for us because you are of color, you're supposed to have a higher pain tolerance, which I feel like in my head probably is that's the case, but I feel like if you're a professional, that shouldn't be the case. You should treat everyone as the same person. And I've heard
Hmm.
other like women when they're giving birth, black women, typically get treated like
Hmm.
almost like I don't want to say animals, but like because they're supposed to have a higher threshold for pain.
Hmm.
So like I guess you're absolutely right. I think everything that you're saying kind of goes hand in hand with that. I mean, to your knowledge, are there any like implicit bias trainings that like doctors or healthcare professionals are supposed to go in through medical school?
You would think, right?
Yeah,
And, I don't want to speak on every medical school that there is in the United States, but I
right.
don't think it's a standardized component of the curriculum. I
Mm,
think when I was doing some research beforehand, I think that was one of the recommendations was there should be implicit bias training. And this I think goes back to one of the conversations that we had in the past, outside of the show is how are we teaching and instructing medical school students? Are we teaching them about the experiences and about the symptoms that African Americans see and experience and have and face that are different than their white counterparts?
mm.
I don't think that's currently being included in the curriculum. In fact, I saw something on the news a couple months ago about a medical student in London that created a handbook to basically teach rising medical students and current doctors on how to identify symptoms of rashes on darker skin tones.
Wow.
And you would think that something like that would be included in your medical school curriculum. But the fact that a medical student was like, all right, this is what it's saying in my textbook, but I don't really understand how I would do this for people that look like me.
Yeah, yeah.
So
That.
I think that there's a lot of work to be done that we would think, you know, should already be there. But, I guess before we get into that, um, when you left the hospital,
Hmm.
what what did you feel was like something that was missing? Like what did you want? Like if there was one thing that you wanted out of that experience at the hospital, what would have it been?
To be honest with you, like the initial onset reaction
Hmm.
was there was nothing there. It was null because I didn't
Right.
know any better.
Hmm.
I didn't know any better. I didn't know the process, and that's
Right.
also another thing. I think black people are less likely to react because they don't know what they should be getting in from the
Sure.
healthcare system, right? As opposed to if you have like a white, let's call it a Karen or something like that, right? Exaggerating, but they
Okay.
would demand and be adamant because they understand
Hmm.
the benchmark, like the
Hmm.
minimum level of like care that they should be receiving, and they will
Hmm.
be more
Hmm.
likely to push for things. I didn't know any better, so
Hmm.
I didn't even feel comfortable even know to even ask for an MRI.
Hmm.
You know what I'm saying? But that experience now taught me that in the future, if this happens to me again, or if it happens to someone that I know or my kid or anything like that, then I can certainly speak to that.
Hmm.
But so like
Hmm.
the onset reaction was no, like there was I didn't
Right.
have any expectations, and
Right.
that's the sad part
Right.
of it. So I get, but now looking back to answer your question, now looking back, if I can take one thing out of it, at least one thing I would say is again, I don't want to say empathy because it's not that there's like lack of empathy, but just the level of empathy needs to be more. There
Hmm.
needs to be more there. Like you need to understand that just because I look a certain way, I look like a healthy young male,
Hmm.
young
Hmm.
black male, doesn't mean that I still couldn't have something severely wrong with me.
Right.
You know what I mean?
Definitely.
I'll
Definitely.
give you another example. Like so, it kind of happened again. Like during like this is post surgery or before surgery, post surgery, I believe.
Okay.
So I had my primary physician who was telling me that he didn't want me to take something they were gonna give me because he didn't think it was like
Hmm.
gonna be based on my health status. It was not gonna be the best
Hmm.
thing for me. But the surgeon's assistant
Hmm.
kept forgetting to like she kept putting that on my script. I'm like, look, I don't think I need this.
Right.
And so she's like, oh, I'm so sorry. Just in your state, I wouldn't expect that you wouldn't need that
Right.
because of my assumption. She blatantly said that, and she was like, I'm glad you called me. You kind of told me about that. And you should
Hmm.
always
Hmm.
make it a point to like remind healthcare physicians that of things that they might forget because that
Right.
just told me that they have biases, they have assumptions. So yeah.
Right. It's it's interesting that you mentioned the term empathy, and it felt like when you were explaining it to me, it was like, oh, is it valid to say that a physician should be empathetic towards me?
Right.
And a physician should always be empathetic towards you because by the end of the day, a physician is there to take care of their patients.
Right.
And I can understand and sympathize from the perspective that sometimes it may feel like that shouldn't be the case. And I
Right.
think that's why a lot of hospitals specifically are focusing on quality. So they'll
Mm.
have these things, these divisions such as quality improvement or quality assurance, and they'll have meetings early in the morning and say, okay, this patient had a terrible experience. What can we do to make that better? Both from a clinical perspective, from an experiential perspective, but not all hospital systems are doing that.
Mm.
Uh, and I think one of the things that's improving in the United States is our shift from fee for service. So being volume centric. So the more patients you have, the more hospital beds you fill, the more money that you're going to make. Shifting to value based care. So the higher quality that you have, the healthier outcomes that your patients receive, the more money you're going to get. And so we're trying to tie financial incentives to that.
Mm.
And part of that is the patient experience, taking into account the experience that a patient and a physician have with one another. And part of that involves empathy. And it's it's very similar, an experience that I didn't necessarily have for myself, but that that my friend told me about when he was working with a hospital and he was working in their heart attack department.
Okay.
And about a third of the patients that come in through the emergency department at that hospital were subject to drug overdose, cocaine or steroids.
Wow.
And it's the bias that occurs even, agnostic of race,
Yeah.
afterwards, okay, they wake up, they're okay. Sometimes they have an actual heart attack and they die, but if they are are able to move past that and live,
Mm-hmm.
then they wake up and then they feel some sort of animosity towards them as if,
Interesting.
why did you do this? And then they feel like that they've received poor care
Right.
because of the fact that they did that. If you were a physician that was truly empathetic and put those things aside, you would still provide the best care that you can and probably even better care
Right.
given that they were in that situation and that they had had a self-induced
So
heart
here's the thing.
attack.
Like obviously we're maybe not like you said, you don't want to speak for every single school, but like maybe we're just
Hmm.
not teaching or we're not standardizing, I think is the word that you use, these
Hmm.
things across the board in medical schools. Do you think these biases are they stemming from like natural everyday, life, or are they stemming from like historical, like because sometimes maybe I'm thinking like when a
Hmm.
physician's like, well, I've seen, if you're a man or if you're a black man, I just
Hmm.
typically on average I feel like you're gonna be more healthy, so I'm not gonna like care. You think it's
Hmm.
stemming from that? And again, I know I'm jumping in the weeds. I know that's not necessarily your
Hmm.
forte, your expertise, but I'm
Hmm.
just kind of
Hmm.
trying to pick your brain to see your thoughts.
Right. I don't like doctors aren't racist. I think it's the fact that we
Right.
live in a society
Okay.
that has this inequality.
Mm.
And I think that's kind of what perpetuates these biases, I think.
Mm.
Um,
Okay.
and it's interesting because you know, you claim yourself to provide equal care, but you have this unconscious bias that actually differentiates the care that you give to somebody who, let's say, is white versus somebody who is black. And it's an interesting phenomenon that I don't think is particularly addressed in medical school today. And I don't think hospitals are providing training on that, especially during a time like today where there's COVID. Um, so I think it goes back to the underpinnings of society
Okay.
that govern the way that we deliver care.
That's a valid response to that. I mean, okay. So kind of like getting back into the whole systemic healthcare structure,
Right.
and we kind of mentioned that the ease of access and affordability of healthcare. There are things, like, especially on the political and law side, trying
Hmm.
to help remediate some of these gaps, right? Um, the Affordable Care Act, aka Obamacare, right? What was that meant to do, and like, what is the current state of that? Has that been successful? And do you think that was the right direction that we should have headed towards it as a country?
Big question.
Huge
Mr.
question.
Gambo with the big questions.
That's what I do, man. Keep on your toes.
The Affordable Care Act, the purpose, in my opinion,
Mm-hmm.
was to give people more insurance,
Okay.
was to make sure that the uninsured rate decreased. I think before Obama went into administration, there was a significant amount of people that were not only not receiving insurance or
Mm-hmm.
didn't have insurance, but were also unemployed.
Yeah.
Um, just to give another example, I think both of those statistics decreased as soon as Obama went into office and after the implementation of the Patient Protection and Affordable Care Act.
Okay.
However, the hope was if people had insurance, people would be healthier.
Right.
That's not the
The case.
case, um, which I think has brought to light that you can't just change the environment.
Mm.
You have to address the socioeconomic factors. And the reason why I bring that up is because the moment when I stepped into my first public health class at UD,
Mm-hmm.
we learned about this pyramid. It was like a 5 tier pyramid, and it talked about the level of impact on 5 levels and what those different ways of making impact would be. The very top is education, and which has the least amount of impact, but is the very easiest thing to implement because it's
Right.
easy to release a campaign or do some marketing, or you and I talking about this is a form of education.
Right.
The most difficult thing is to address the socioeconomic factors like racism, discrimination, inequalities,
Mm.
implicit biases. And then the second most difficult thing that has a decent amount of impact is kind of changing the environment. So introducing new payment schemes, introducing financial incentives that tie back to quality so that way you can bring value-based care,
Mm.
or ensuring that people have better access, or there's more ways to gain insurance and health insurance. And it's interesting because I think that there's something in between those two things
Mm.
as it relates to changing the way that we perceive care and changing the way that we deliver it.
Mm.
It's not just implementing the payment schemes and letting them stand on their own, and letting physicians and providers and pharmaceutical companies, whatever the case may be, do what they want and deliver them the way that they want. I think that there needs to
Right.
be something in between so that way patients are heard and providers' needs are met, so that way both can kind of have that win-win situation. And I think that's kind of the crux of healthcare that I think everybody is always trying to solve is alignment. And I
Right.
remember when I was in public health school, that was like the hardest thing for us to even think about.
What do you
How
mean
can you
by
be aligned?
alignment?
So, to be transparent, I work with pharmaceutical companies.
Uh,
So, I'm talking about
I'm sorry.
I'm talking about healthcare access and affordability. And I mentioned the term that I work with pharmaceutical companies, and you're probably like, what the hell? Like, that doesn't make any fucking sense.
Yeah,
So,
yeah, yeah.
what I specifically enjoy about the work that I do is I bring that topic to life when I work with my clients.
Okay.
And I try to let them know it doesn't matter how innovative or how cool or how superior this product is. If a patient doesn't buy into it, you're not going to make any money. So, going back to alignment, there's this aspect of like, walking the square. So, the needs of the patient have to meet the needs of a provider that also
Mm-hmm.
have to meet the needs of a payer that also have to meet the needs of a pharmaceutical company. All those things have to walk the square and be aligned. If they're
Mm.
not, then you don't have a successful healthcare system. You have a broken one in which maybe two of those things see eye to eye, but all four of them don't.
Mm.
And I think that's the case that we have in the United States.
So I got a couple things from that. One is that healthcare is certainly a business.
Healthcare is a business in the United
Right.
States.
Okay. Quick question is, and you don't have to answer just now because I have a second question as a follow up. But
Okay.
is that the case in other countries that are doing better than we are in terms of healthcare?
I'll answer it now, and it's no.
Oh, okay. So it's still a business regardless of where you're at.
It's so, let me rephrase. I think healthcare is more of a business in the United States than it is in other countries.
Okay, cool.
Because in other countries, you have a public health insurance program where you can receive any care almost free of cost in some cases, like in Germany, for instance.
Yeah.
Um, but in the United States, there's all these different payment schemes to incentivize patients and providers to choose one over the other. And I think that introduces a strategy that medical device companies and pharmaceutical companies have when they enter the United States. Are like, okay, how do we make money given the fact that there's all these different pathways that we have to navigate as it relates to
Right.
reimbursement and payers. Whereas when you enter the Germany market, you're just working with one. You're working with one payer. It's the national health insurance system.
Mm.
Um, there's less complexity associated with that. And by the end of the day, patients are receiving care for free most of the time.
Okay.
Whereas here in the United States, sometimes you have to deal with out of pocket costs,
Yes.
the additional revenue that you may be getting as it relates to copays or premiums, etc. And, I think that varies globally, but it's more so of a business here in the United States. And I think that is just due to our capitalist culture, if you will.
I was going to get to that. So here's the thing. I think in the pyramid that you were talking about, the second layer, I was actually very interested about because you mentioned, the financial aspect of it, right?
Right.
So I think a lot of times we don't notice how political healthcare becomes in the United States. I don't know what it's like in
Hmm.
other countries, but I mean, I know for sure here. Like even when you take something that's like as simple as the Affordable Care Act, I
Sure.
understand that the proposal and what manifested from that proposal are two vastly different things.
Hmm.
It's not what necessarily was proposed. And so when you look at someone like Bernie, who was talking about healthcare for all, and tied in with a capitalistic society, me just being someone who studied economics alongside with you, like
Sure.
that just sounds kind of crazy. Not even kind of crazy. It sounds absolutely crazy if you're in the
Right.
United States. It's almost like, yeah, this dude is wilding. Like that's not gonna happen. You know what I
Yeah.
mean? Because of
Yeah.
the capitalistic nature and the political nature that goes into making these laws and
Right.
passing these things. So I think that's very very interesting. Also, you mentioned something that's also interesting is that you mentioned that like you didn't say it, but I'm gonna simplify it. I guess
Okay.
to my own from my own perspective,
All right.
is that healthcare in the United States I think is very confusing.
It is.
It's very perplexing. It's like there's deductibles, there's co-pays, there's like all these out-of-pocket costs, in
Hmm.
network, out of network, all the like, then you have people
Yeah.
who are, have providers from whether they get company provision of healthcare or they
Hmm.
have, like independent individual and all these people are competing against each other. And
Yeah.
you have FSA, HSA, like you have all these crazy like little caveats like that's
Yeah.
them out of healthcare that I think is very daunting to like the average consumer or just the average person. Coupled with the fact that, multiply with the fact that someone who might be from like the hood or somebody who's not necessarily familiar with any of these things,
Sure.
like how do you get started unpacking all of these layers and really trying to like get the best value from a system that's built like that?
It's a big question. To become a well informed patient, I think in part it takes a little bit of experience and understanding what you may not receive if you were to seek for care. So, in the example that you provided, you went to the hospital and you felt like when you left that there was something that you didn't get. Uh,
Yeah.
and then that's when you understand, all right, there's something that I'm not getting. But I think there's loads and loads of information that go into the US healthcare system that you just have to unpack like an onion more or less.
Yeah.
And I think and I think when you think about the US healthcare system, it's like putting a band-aid on top of another band-aid again
Yeah.
and again and again and again. And it's like it doesn't quite cover the entire wound.
Right, right.
And that's why there's these drastic
Mm.
proposals such as fuck it, Medicare for all. And at first you're like, this guy is wild and like what
Right.
is up with this?
Right, right.
But to some extent, depending on what side you fall, it makes sense. Uh, because of the fact that it's so broken, it's like, all right, we need something new.
It's Nadine for Medicare for all.
Nadim is not
Okay.
Medicare for all,
Why not?
specifically because I think it's one, I don't think it's feasible. I
Is it
don't think it's
possible?
feasible. It's possible to implement, but similar with the ACA, is it going to deliver the outcomes that we need?
Right.
That I don't believe in. I don't. Medicare for all, is that going to give us what we need? What is that going to mean from a taxes perspective?
Well, that's a whole other topic, man. But what
Ta-
do we need?
what we need, in my opinion, is to address the upstream, to
Meaning,
address the distrust, the
mm,
inequalities. It's, yes, insurance exists, Medicaid exists, ACA exists, Medicare exists. There's going to be out of pocket costs. And that's, I think, something that I think politicians are trying to solve. How can we make healthcare cheaper? But I think the aspect in terms of how can we improve healthcare outcomes, I think that all has to do with the social injustice that exists in our country.
okay, that's a fair point. But I definitely want to be realistic too. Like, I mean, while those are all nice sentiments, I think a lot of people who are stricken by poverty, right? I think
Sure.
also they would want just the affordability. So for somebody like that, and like I think you
Hmm.
mentioned something I was pointing earlier, you said depending on what side you're on, like because
Yeah.
someone who's poor, like to them, they probably don't necessarily give a shit about how much empathy you treat me with, right? I'm
Right.
sure they would like that, but it's like, am I gonna
Hmm.
get treated for free, right? So
Right.
is that a fair, is that a fair thing to ingest in this conversation?
So repeat that one more time because I think I have an answer, but I just want to make sure that I'm hearing you right.
Right. So I'm saying, we mentioned that, we would like to have empathy,
Right.
kind of like you said, address the upstream, address all
Right.
the underpinnings that, are wrong
Hmm.
with the healthcare system. But within that, I think one of the biggest ones for people who are in disenfranchised communities or
Hmm.
are stricken with poverty is affordability. Like, at the
I
end of
agree.
the day, how can I pay for my shit to be right? How can if I
Right.
broke my leg, how can
Right.
I get my leg right?
It's a good question, and I'll start by explaining a story from myself because
Okay.
growing up, I was on Medicaid my entire life.
Right.
Single mom,
Right.
struggling to pay bills.
Right.
So there was times when I went to the doctor's office and they don't accept Medicaid. I'm like, I
Shit.
can't get my teeth clean.
Right.
I can't have my yearly checkup. Like, what the fuck?
Yeah.
Like, doesn't make any sense. Can't get my damn teeth clean. Um, so totally understand. I think that a lot of that comes onto the state level.
Mm.
So part of the Affordable Care Act was to expand Medicaid, expand the amount of funding that Medicaid can offer on a state by state basis. Some states did not opt in to the Medicaid expansion.
Mm.
A lot of
You're
that
right.
is centered in the South. So a lot of southern states did not expand Medicaid.
I remember that. Yep.
So I think part of that is working with states specifically to improve that access so that way people can potentially get cheaper and more affordable care. And I think it also requires entities within a local region and within a local proximity to begin addressing those aspects of affordability. How can we encourage payers to provide these preventative services at a low cost? How can we encourage hospital systems to provide certain programs or initiate certain programs so that way people who don't have the right access or can't afford care can receive it? It's an interesting medium between what we have today and the Medicare for all plan.
Mm-hmm.
Um, and I think it'll take some time for us to get to that medium, but it's interesting. It so kind of where we are today is not sufficient, and where Bernie Sanders at least wants to go is also not realistic.
Right.
So what is the medium in between where we can have something that's semi-realistic and semi-sufficient?
Right.
Um, and I think it goes back to the historic ways in terms of how do we get here?
Yeah, I mean that's a good point, and I think whenever you talk about healthcare, that's like the biggest point of contention because it's like you mentioned, like just finding that sweet spot is damn near impossible because you're dealing with a vast majority of different, like you're dealing with a bunch of different people, right? And
Right.
from across the spectrum, like and in different facets. Like dealing with people in different socioeconomic statuses. You're dealing
Hmm.
with different people with different ideologies. You're dealing with a
Right.
bunch of different people. So it's certainly
There's so
difficult.
much that goes into it, and it kind of goes
Yeah.
exactly to what you're saying. It's very political.
Right.
Very.
I know we're almost out of time, so I don't. I definitely want to try to wrap it up, but I have a question to ask as well. So
Sure.
like I read somewhere there's like about 650,000 people go bankrupt or something like that in the U.S. just due to medical bills. So
Yeah.
that like every year, that's crazy. That number is astronomically high, and so coupled with like affordability for our brothers and sisters in Black and Brown communities in disenfranchised places, and how do we what do we do to try to get good quality care or decent quality care, and also how do we try to maneuver and navigate around some of the complexities within the healthcare system. And I guess as a last takeaway question as well, what would you propose for our healthcare professionals? What would you propose to them when dealing with black and brown patients? I know it's a lot of questions right there, but anything you could provide with us that would be super helpful, man.
I think the most important thing to know when you're consuming care, when you're going in for a treatment, when you're going into the hospital, is to recognize the implicit bias and the disadvantage that one may be subject to,
Mm,
and understanding that the standards of care that you may be receiving is not the actual standard of care that you should be receiving. And I think that is, I think, the first step in letting the system, letting the system know
right.
that there is inequality. And I think that's what initiates change. And you would think that, all right, that's not my job to let somebody know that they're doing their job wrong. But it's come to that point, and I think that's kind of the first step in understanding the care that you should be receiving. If your leg is broken and you should be receiving an MRI, and the doctor tells you, I don't think you need an MRI, you have every right to say, I think I need an MRI.
Mm,
And I think that's something that I've specifically seen in the work that I do. We keep focusing on a well-informed patient that knows the technology and the digital
right.
health and everything that they know about their insurance. When I was before I was even like super involved in healthcare, I didn't know jack shit about like
Right.
insurance or anything like that. So whatever health well-informed patient people are talking about is are the patients that have the privilege and the means to learn that information and
Mm,
aren't subject to the things that people in black and brown communities are subject to today. So I think that's kind of the first step. And I think in terms of what needs to be done nationally, I think it's hard. I wish I had the right answer. Um,
yeah.
but I think it's just continuing to educate and train and mitigate the inequalities that we see in the delivery of care.
Mm,
I think that's kind of the first step, and then working upwards from there or downwards from there, however which way you look at it. We see today that there's this implicit bias, which is a result or an effect of poor delivery of care between African Americans and non-African Americans. What does that say about the healthcare that we provide in the United States? And then we bubble that up, and then we see, okay, what are we doing actually? How are we providing care? And then we address that question. And then we address that through policy or through advocacy or whatever the case may be. And then we bubble that up and be like, all right, what does US healthcare look like? What are we trying to do in the United States? And I think we're slowly making that pathway. It's just a matter of identifying what those downstream impacts are and then working our way up.
Okay. Yeah, I appreciate that, man. So the way what I just took away from what you just said, I think is profound. I pretty much just heard that we need to educate ourselves as people whenever we're going into healthcare facilities. Understand that there are going to be implicit biases, maybe not, but we need to be aware of those instances when they do occur, and be firm in our, like, and basically know our rights, know what we are, what's at our disposal, if you will.
Right.
Right. So, and also the education piece, and also I'm hearing basically like vote at the state level to try to get people elected in office who will be for your rights or for your points of views, and I think that's really dope.
Hmm.
Unfortunately, there's so many things that I feel like I really want to talk about. Unfortunately, we are like out of time, and we didn't give a chance to talk about the disproportionate effects of COVID or anything like that. We didn't even get a chance to touch more into the Tuskegee study. But it's always a pleasure to have you, man. I would love to have you back on here again. I think I learned a lot. I'm sure people who are tuned in are learning a lot. So it's always a pleasure to have you, Nadim. Appreciate you, brother. Thank you for coming. You got any last words or anything like that, man?
Thank you for having me. And I think one thing that I would say to echo where my studies came from is that health is a human right.
Mm.
And to understand that and to promote that and advocate for that and know that that is what stands true and that's what you should stand up for.
Damn, this man is good. I heard the man. Yo, is there any way they can follow you if they want to like check you out? I know you're not super out there, but if people want to like reach out to you, can they reach out to you? If not, it's all good too.
Yeah, so I guess in terms of like social media, feel free to reach out to me via LinkedIn, and we can talk more. It doesn't necessarily have to be about a business matter, but just simply to just chat. Um,
Word.
I'm always willing to talk to people about how they can get more involved in healthcare.
Word. I'll definitely make sure to put a link down in the description. For everybody
Hopefully.
tuned in, thank you so much for tuning in. We always appreciate y'all. Make sure that catches out on Apple Podcasts, Spotify, Google Podcasts, wherever you listen to your podcasts on. Make sure you also check us out on Instagram and Mentality Radio. And until the next time, we'll catch y'all. Deuces.